Okay. All right. Hello, everyone. Welcome to our teaching point recap session. We are presenting the key learning point from all recent VMR case. We have only 1 month left, so let's make it meaningful with an amazing set of recap presentation. I'm a Himun from Korea, your moderator today. And I'm very excited to introduce our wonderful global presenters, Magnus from Denmark, Aaron from New York, and Glenn from Botswana. If you have any question, please write them down in the chat. Magnus, you will go first, and please introduce yourself and start your presentation.
Hello everyone, my name is Magnus. I'm from Denmark and very happy to be here today. And thank you for hosting, Heman. I really love these teaching point recap sessions. I'll just start by getting my slides to work. So I'm gonna recap a case that was presented by Alec, which I thought was really fascinating. He presented it to me. It was actually my first discussion, and then Rabi also. I think after that, I really had a lot of reflection to do, and I really think that there are so many concepts that could be recapped here. So the case started with a 34-year-old female with a past medical history of uncontrolled HIV who presented due to acute nosebleeds and also subacute inflammatory symptoms in the form of weight loss, fever, and night sweats. And she was also found to have these diffuse red papular lesions. So the first question I have for you guys are what is an opportunistic infection? How do you think about that concept? So please put your answer in the chat if you can. Yeah, exactly. Yeah. Yeah, so you're spot on, Similira and Manaswini. So an opportunistic infection in the context of HIV are infections that are either more frequent or more severe. And this is all due to the HIV-mediated immunosuppression. So we can think of them in different buckets. And there's a really nice schema about this on the website. So one bucket are the routine infections that we see in immunocompetent patients as well, but they just present with more severe symptoms. And those could be, for example, strep pneumo or granulomatous diseases like TB. And then we should also be thinking of STI, so other STIs in HIV patients, because when you have one STI, you may share some risk factors with some of the other STIs. And again, these different diseases may present with a more severe presentation. And these are the usual ones we think about. So viral etiologies like herpes and hepatitis, and then also bacterial diseases like gonorrhea, chlamydia, syphilis. And then finally, the bucket that we should be entertaining are the infections that are driven by the deep HIV-mediated immunosuppression, mainly due to the low CD4 count. And these can be divided into different buckets depending on how deep the immunosuppression is and how low the CD4 count is. But these include fungal diseases and like Cryptococcus and PCP, but also parasites and viral diseases again, and mycobacterial infections also. So there are many. It really expands the differential when we have severe immunosuppression. So the case continued with the physical exam and the lab. So the patient had diffuse lymphadenopathy, hepatosplenomegaly, anemia, and thrombocytopenia, and then a very low CD4 count at 11. and a high viral load. And the patient also underwent a very large ID workup that was negative, except for an AFB blood culture that was positive for MAC, but that was 1 month ago, and the patient didn't receive any treatment for that. So we started to wonder whether the current presentation could be related to this disseminated MAC infection. So if we'll just briefly discuss that entity. It usually occurs in patients with a CD4 count under 50, and it happens due to inhalation or ingestion of these mycobacteria that invades the gut. And from there, it can really spread through the lymphatic system or hematogenously. And that is why we can get different symptoms. So we can get non-constitutional symptoms that are non-specific. And then we can also get some GI symptoms like diarrhea and abdominal pain. And due to the spread through the lymphatic system, we can also see anemia, hepatosplenomegaly, and also diffuse lymphadenopathy, as was the case in this patient. And sometimes, if the CD4 count is higher, it can present with more localized disease because the body is better to contain the infection. So, what we also found in this case was that the patient actually restarted antiretroviral therapy 1 month ago, followed by the worsening of symptoms during the last few weeks. So, which inflammatory syndrome should we consider in this case? Does anybody have an idea about that? You can please feel free to post in the chat. Yeah, exactly. So Hans and Praveen are spot on. It's what is called IRIS, which stands for Immune Reconstitution Inflammatory Syndrome. And it's really a paradoxical worsening of symptoms that occur after the start of or restart of antiretroviral therapy. And it's mainly because the immune system begins to recover, so it awakens, and then it can react to an infection that's already present in the body. And this may be associated with many different infections, but mainly mycobacterial infections, fungal infections, and some viral infections again. And it can really look like that the infection is getting better. The infection is getting worse, but actually it's not the infection, it's the immune system that gets better to respond. And it's also really important to notice here that cancers may also manifest as this syndrome. So that made us consider some of the HIV-mediated or associated cancers, which are mainly due to different oncogenic viruses, mainly HHV8 and EBV. So these may cause, for example, Kaposi sarcoma, multicentric Castleman's disease, or different types of lymphoma. But there are also solid cancers that are, for example, HPV mediated. And apart from the cancers, there are also autoimmune reactions associated with HIV and also many different organ-based pathologies that I'm not going to go into here. So finally, in this case, tissue was the issue, and there was a biopsy performed on these skin lesions that showed bacillary angiomatosis, which is an infection caused by Bartonella species. And if it's Bartonella henselae, there's often a history of cat exposure. And it's almost exclusively seen in immunocompromised patients with a low CD4 count. But actually, if you are HIV patient with a Bartonella infection, bacillary angiomatosis is the most common form. And they usually present with vascular lesions of the skin, like in this case, but it can also be vascular lesions in other organ system as well. And there are many variations, but often they are papular or nodular in appearance. And since this is also a disseminated Bartonella infection, it may also give rise to lymphadenopathy and sometimes also involvement of liver and spleen. So we can also see that in HIV patients. And the DDX is mainly Kaposi sarcoma, which also is a vascular tumor. And then other like more benign, usually skin or vascular lesions. And it's really important here to remember that serology can be negative. So that's actually in nearly 25% of patients with HIV and bacillary angiomatosis. And that's simply because the immune system is not capable of mounting a response that we can actually measure. So finally, first-line treatment is doxycycline or erythromycin, and actually the patient did receive doxycycline during the last admission, which improved the symptoms. So that was also a clue to the final diagnosis here. And finally, the take-home messages. So if you have an HIV positive patient that presents with inflammatory symptoms, think of opportunistic infections, HIV-associated cancers, and autoimmune diseases. Um, if they recently restarted ART, think of IRIS, so paradoxical worsening of symptoms. And Bartonella infections may present as a bacillary angiomatosis, which are the vascular lesions, and serology can be negative in these patients. So my final words as a dog person is just going to be that don't buy a cat because I think this great argument for that. So thank you very much for your attention.
Thank you so much. That was amazing. Like capturing all those important key points. It was excellent. But I still want to buy a cat. Okay. All right. Yeah. Anybody if you have any question, please leave on the chat. And then Aaron, I think you're next. Give us your amazing presentation when you're ready.
All right, can you guys see my screen? Okay. So, hey guys, I'm Aaron's. I'm a medical graduate from the Philippines, and today I'm going to be sharing a teaching points recap from a case that was presented on November 15th by the Allegheny residency program. So, for the HPI, quickly, for this patient, it was an 89-year-old female with past medical history of low-grade B-cell lymphoma, hypertension, and a patent foramen ovale with a right to left intracardiac shunt. She was seen in the ED after a mechanical fall down 12 steps, and she sustained a head injury. Physical exam was notable for hypertension to the 200 systolic and good O2 saturation on room air initially. The patient was also noted to have injuries on her scalp and bilateral elbows. The remainder of the exam, including the heart and lungs, were otherwise unremarkable. For imaging, the workup was notable for CT head imaging that revealed trace intraventricular horn hemorrhage and CT abdomen and pelvis with diffuse lymphadenopathy in the abdomen and pelvis, which is consistent with the patient's known lymphoma. And there was noted to be no pulmonary embolism. The chest x-ray was noted for a right-sided opacity concerning for pneumonitis versus aspiration pneumonia. So in the ED, the patient had a laceration repair that she tolerated well. And though the patient was initially satting well on room air, she was noted to desaturate down to 70s to 80s with movement. This was initially correctable on 1 to 2 liters of oxygen. And at that time, the patient reported that she felt more short of breath when sitting up, which was improved when laying down. Eventually, the patient continued to desaturate even on 15 liters of oxygen and was eventually placed on high flow nasal cannula. So to summarize this main problem, we have an 89-year-old female with past medical history of a PFO with right to left intracardiac shunting, presenting now with shortness of breath that worsens when sitting up and improves when laying flat, and hypoxemia that's not correctable with low flow oxygen. So the question becomes here, what is causing this patient's hypoxemia? So to help elucidate the problem, the following slides will discuss the common etiologies of hypoxemia. So some 5 mechanisms of hypoxemia include hypoventilation, a hypoxic environment, VQ mismatches, shunt physiology, and diffusion abnormalities. So the following slides will include cases to further highlight these mechanisms. So the first question I'd like to ask the chat, A patient with ARDS has a PaO2 that barely increases even on 100% O2. What is the most likely mechanism of hypoxemia? And I can't even see the chat for people who want to answer. So actually, for this patient, this is a shunt physiology. So in ARDS, this is actually a pulmonary shunt. So in this case, there's zero ventilation to the alveoli. So while there's still adequate perfusion, this zero value in the V portion of the VQ uh, represents pulmonary shunting. So shunted areas have no ventilation. So providing even 100% O2 will not improve the patient's hypoxemia. So we can go to the next question. A patient with lobar pneumonia develops hypoxemia that improves with supplemental O2. In this case, what is the most likely mechanism of hypoxemia? Anyone in the chat? So for this case, it's actually VQ mismatch. So compared to the last case, which was a pulmonary shunt where the V value is zero, in VQ mismatches, the V value is a non-zero value. There's still some ventilation, though it is a little bit decreased. So in pneumonia, parts of the lung fill with pus and fluid, and these alveoli become poorly ventilated and can't get enough air in. So, however, the blood flow to that area stays normal. So ventilation goes down while perfusion stays the same. So that's why it's a VQ mismatch. All right. For the next question, we have a patient on high dose opioids that has a low PaO2 with an elevated PaCO2 with a normal AA gradient. What is the most likely mechanism of hypoxemia here? Yes. So for this one, we have hypoventilation secondary to the uh, decreased respiratory drive due to the high dose opioids. So this leads to decreased oxygen delivery to the alveoli with decreased CO2 removal as well, which would decrease the PaO2. So for the fourth question, we have a mountain climber at 14,000 feet that develops hypoxemia with a normal AA gradient. What is the most likely mechanism of hypoxemia here? Yeah, so this one is B. So at 14,000 feet, the air is thinner. So uh, there's a lesser total atmospheric pressure. So the partial pressure of oxygen entering the alveoli drops, leading to hypoxemia with a normal AA gradient. For the fifth question, we have a patient with idiopathic pulmonary fibrosis that develops shortness of breath on exertion with low PaO2, but normal oxygen at rest. What is the most likely mechanism of hypoxemia here? Yeah, so for this one, it is a diffusion abnormality, since in patients with IPF, fibrosis in the alveolar walls causes thickening, thus causing a decreased diffusion of O2 from the alveoli to the capillaries, resulting in a decreased PaO2. So finally, for my last question, you go back to this patient. A patient with a PFO with a right to left intracardiac shunt develops hypoxemia that is worse with sitting up and improves when laying flat. What could be the most likely mechanism of hypoxemia here? Yeah, so for this one, it is shunt physiology, but contrasting to the ARDS, which was also shunt physiology, this is a cardiac shunting physiology, which I will further explain. But to further approach this systematically, we have the hypoxemia thought train schema that we can use. So first, for this patient, we need to check the O2 sat. So the patient was noted to be desaturating to the 70s to 80s despite 15 liters of oxygen. So this implies an increased AA gradient where the alveoli and vessels are not communicating, thus leading to hypoxemia. So the next step down this pathway is to listen to the lungs. So to differentiate if this is an alveolar problem or a vessel problem. So in our patient who was noted to have a clear lung exam, this suggests that the problem is not at the level of the alveoli, but instead is at the level of the blood vessels. So we need to then figure out if there is a blocked vessel, such as in pulmonary embolism, or if there's a bypass of the vessel, such as in shunting. But as we know, the patient had a CT abdomen and pelvis, which noted no pulmonary embolism, which leads us to shunting physiology, such as an intrapulmonary or intracardiac shunting. So this patient happened to already have a known patent foramen ovale with right to left intracardiac shunting, so that could predispose her. So ultimately, this patient was diagnosed with acute hypoxic respiratory failure with severe right to left intracardiac shunting, leading to platypnea orthodeoxia syndrome, secondary to flash pulmonary edema and aspiration pneumonia. So I know that's a very long diagnosis, so we can break this down and focus more on the platypnea orthodeoxia syndrome part. So to understand platypnea orthodeoxia syndrome, we first need to define what is platypnea and what is orthodeoxia. So platypnea refers to improved difficulty of breathing when laying flat. Orthodeoxia, on the other hand, refers to desaturation in the upright position. So together, these two define platypnea orthodeoxia syndrome, which is the opposite of what we typically expect in cardiopulmonary disease. So, for example, in patients with heart failure, we would expect their symptoms to worsen when laying flat, which is what we call orthopnea. In this example, this is because in the supine position, there's increased pulmonary venous pressures that worsen congestion. So the patients feel better when they sit up, but this is not the case for our patient. She actually felt worse when she was sitting up. So this is actually what happens in platypnea orthodeoxia syndrome. So in this syndrome, the issue is a posture-dependent right to left cardiac shunt. So while the patient is upright, where we would expect them to actually feel better, they actually have positional changes that worsen the right to left intracardiac shunt. So this worsening of a right to left intracardiac shunt actually leads to the mixing of deoxygenated blood with oxygenated blood, which is then sent to the rest of the body, thus producing the desaturation. However, in the supine position, this vulnerability is decreased, leading to improved oxygenation. But to further explain this, let's first break down the essential components for POS to occur. So there needs to be both an anatomical component and a functional component. So first is the anatomical component. There needs to be a passageway between the left and right atria that will allow the blood to flow from the right side of the heart to the left side of the heart. This could be either a PFO or an ASD. So on their own, these usually don't cause right to left shunting. So as we know, left atrial pressures are higher than right atrial pressures. So we would expect them to drive flow from the left to right, and which would not normally cause any hypoxemia. So the question is, why is this passageway necessary? So as mentioned, we know that blood in the right side of the heart is deoxygenated as compared to the blood from the left side. So if we allow this deoxygenated blood to mix with the oxygenated blood from the left side, this blood with decreased oxygen is getting sent all throughout to the body, leading to decreased oxygen delivery. But without this passageway, we wouldn't even be able to have a right to left shunt uh, to occur. So we need this anatomical component. So secondly, we need a functional component that favors the movement of blood from the right side of the heart to the left side of the heart instead of the usual left to right movement that was already present with the anatomical component. So it's from this movement of deoxygenated blood from the right to the left of the heart that causes hypoxemia. So these functional components can be from various causes, as seen here. And what all these have in common is that they can distort the position or the angle of the atrial septum so that when the patient is upright, where we would expect them to actually feel better, uh, it puts them at a disadvantaged position where blood is actually redirected through the anatomic component, which in this case is the PFO, that allows for the blood to flow from the right to the left. So to go back and explain the symptoms, so standing or sitting up redirects venous blood toward the PFO. So this occurs because gravity changes the septal angle. This leads to an increased opening of the PFO flap when the patient is upright. So from this enlarged space, blood can flow more easily from the right side of the heart to the left side of the heart. And this only occurs in the upright position because of the effects of gravity. When the patient resumes a supine position, such as laying flat, the septal angle shrinks and decreases the PFO flap opening and doesn't allow as much blood to flow through. So let's go back to this patient. How did she get her POS? So her components, she has a anatomical component of a PFO, which will allow for the interatrial communication. So this passageway will allow blood to move from the right side of the heart to the left side of the heart. under the right circumstances. Unfortunately for her, she already has known right to left intracardiac shunting at baseline, so she wouldn't even need that much more to consistently push deoxygenated blood from the right side of the heart to the left side of the heart. For her functional component, she had flash pulmonary edema and aspiration pneumonia contributing to her POS. But the question is, how does that flash pulmonary edema and aspiration pneumonia contribute to her problem? So for her flash pulmonary edema, this would eventually result in increased pulmonary venous pressures, which in turn lead to an increase in right-sided heart pressures. So just a small increase in the right atrial pressure can favor the right to left shunting of blood through the PFO, predisposing her to POS. Additionally, for her aspiration pneumonia, right-sided aspiration pneumonia, as seen on her chest X-ray, increases pulmonary vascular resistance through hypoxic vasoconstriction. This increased PVR likewise increases right-sided heart pressures, which can increase right to left shunting through the PFO. So the presence of both of these pathologies together predisposes this patient to her presentation. So just some take-home points. Hypoxemia has a few core mechanisms, as we've discussed and seen through the cases. And POS is an intracardiac shunting problem that requires an anatomic and functional component, as seen in this patient who had a PFO, as well as aspiration pneumonia and flash pulmonary edema. In POS, symptoms improve when you're supine due to decreased flow through the shunt. And pulmonary disease, such as aspiration or flash pulmonary edema, can act as the functional component. And that is all. These are my references, and thank you for your attention.
Wow, that was amazing, Aaron. I mean, yesterday it was amazing, but it ends up more amazing and amazing. Yeah, I love so much. Thank you so much. And the most amazing presenter, Glenn, is here. Glenn, are you ready? If anyone have a question, please, leave the question on the chat.
Hello everyone. Is my screen visible there? Are my slides visible? Hello?
Yes.
Okay. Hello everyone. So my name is Lena. We doing the tissue points recap for the case that I presented on the 11th by Jeffrey. It was a great presentation, and I wanted to learn a few things from the presentation and ended up doing the recap. So for the present presentation, this is a 24 years old African American male presented with diffuse itching together with fatigue and joint pain for 3 months. Also had hyperpigmented nodular lesions. Also had swollen neck, dry eyes, and dry mouth. For the past medical history, had history of recurrent uveitis and arthritis. So just to talk about approach to itching. So you can ask about any associated rash, any medications that were used, because some of them can end up causing the rash. Itching, either itching alone or with rash. So some of the drugs that can do this are the ACE inhibitors, the beta blockers. Also ask about any exposures to maybe hair dyes, nail polish, but there are other exposures out there that can cause itching as well. And it's important to differentiate exogenous versus endogenous causes. So with endogenous causes, just thinking of organ failure, thinking of the kidney, renal. So increased bilirubin levels and bile acids can cause itching. So with things like primary biliary cirrhosis, and some endocrine dysfunction. So with endocrine dysfunction, thinking of the thyroid, either hypo or hyperthyroidism, can cause itching. So that's how you would think about itching and try to differentiate causes from each other. So the patient also had joint pain as well, in addition to the itching. So anyone who can just say maybe a few, 2 or 3 questions that you would want to ask in history when evaluating joint pain. I can't see the chat if anyone has said something in the chat. Someone can mention them. Just 1 or 2. Okay, so moving on. So joint pain, you can first you want to know if it's multiple. So if it's just one joint involved, multiple involved, then try to divide causes into localized and systemic, right? So with localized inflammation, it will be with use and better in the morning, worse in the evening. So here we'll be entertaining things like hemochromatosis and osteoarthritis, with osteoarthritis affecting mostly weight-bearing joints. So in contrast to that, systemic inflammation will be more painful in the morning. It will improve with movement. So here you can further on divide the causes into symmetric and asymmetric. With symmetric thinking of SLE, rheumatoid arthritis, then to differentiate the two, just look for extra features of those two conditions. So with SLE, you look for malar rash, oral ulcers, to differentiate it from rheumatoid arthritis, which will prevent with some deformities like ulnar deviation, so neck deformities. You can even do lab tests to differentiate the two, like rheumatoid factor and ANA. If it's symmetric, however, you can then divide the causes into whether they involve whether there is axial involvement or not. So here we'll be thinking about spondyloarthritis, things like psoriatic arthritis, inflammatory bowel disease, reactive arthritis, and we'll then look for any features to suggest both the 3 diagnoses. So with psoriatic arthritis, looking for the rash of psoriasis, inflammatory bowel disease, asking for any associated diarrhea. So just to summarize what I just said about the approach to joint pain, so localize it, small, large joints, symmetric, whether symmetric or asymmetric, inflammatory versus non-inflammatory, and look for associated features based on the differential diagnosis that we have. So going back to the patient had a past medical history of asthma, past family history of SLE, Crohn's disease, and sarcoidosis. On examination, had cervical lymphadenopathy, parotid fullness, the skin had excoriation and hyperpigmented plaques. On the musculoskeletal system, there's some thick synovium in the wrist and the ankles. So on the cervical lymphadenopathy, just anyone who know an approach to categorize the causes, like in which buckets would you entertain when evaluating cervical lymphadenopathy, like which big categories would you have in your mind to differentiate the causes of cervical lymphadenopathy? So I cannot see what people are saying in the chat, but I would assume if there's someone who said something in the chat similar to what I have here. So here I have the 3 categories for evaluating cervical lymphadenopathy causes. So we can have infection, autoimmune, and cancer. So with infection, here it will be mostly you differentiate according to the clinical picture. of the patient and the age group. So with viral, most common being Epstein-Barr virus, there's also CMV and HIV. With bacterial, you can think of syphilis and group A streptococcus. Um, others, other bacterial ones are TB and Bartonella. So here we'll be entertaining them based on if they have other features that points to TB and Bartonella. So with Bartonella, just with Magnus case, any exposure to cats, TB, usually any immunocompromised state. Other autoimmune disorders, IgG4 disorders, and SLE can cause cervical lymphadenopathy. Cancer, you would divide them into solid or liquid cancers with entertaining things like squamous cell carcinoma and lymphomas. So that's how you would approach cervical lymphadenopathy. So going back to the patient again, for the labs, I only picked like pertinent positive findings here. So there's some renal dysfunction with a creatinine elevated at 1.6, some liver enzymes elevated, TSH elevated also, and then the IgG was markedly high, so there's some polyclonal gammopathy, and then we also did some autoimmune panel, which was all negative. So further investigations, we did imaging. So CT showed diffuse lymphadenopathy, the liver mass-like lesion. The biopsy showed non-cassating granulomas, and the kidney showed mesangial IgA deposition. The transbronchial biopsy showed granulomas, and the cultures were negative. So the last test to be done was the next generation sequencing, which showed a gain of function mutation in the node 2. So with this, I would ask which diagnosis would come to your mind given this imaging findings. Just type in the chat what you think could be diagnosis from these imaging findings, and I would hope people will type in sarcoidosis. And the diagnosis actually early onset sarcoidosis, which is also referred to as Blau syndrome. So I actually chose to do teaching points on this case because it was my first time hearing this name, the Blau syndrome. I wanted to know more about it. So Blau syndrome is an autosomal dominant granulomatous disease, especially another name for it being early onset sarcoidosis. Actually, mostly presents in early childhood. It has a triad of dermatitis, uveitis, and arthritis, and can also present with other symptoms like here. Also had cervical lymphadenopathy. The cause for it is a gain of function mutation in the node 2, like I mentioned. And the management, the most common drugs that are given here is methotrexate, 10F inhibitors, and MMF. So that's all. These are my references, and thank you everyone for your attention.
Well, Glenn, thank you so much. Now I understand what is flow, right? Let's not forget about that. It was my honor to work with such amazing people. And then I just wanna, before I end this session, I'd like to share a few words with anyone going through a tough time because this is last month. If you're facing a hard choice, listen to your heart because you know yourself fails and choose the path that feels true to you and give it to your best so you will never regret it. And I think all CP Soba member are like that. So I wish you all the best. I hope we can finish this month with a smile and a hope. Well, see you next time, and thank you for being with us.